Okay. With the next one, you had a 30-year-old man who was assaulted with a baseball bat and he was struck on his right collarbone. He's holding his right arm close to his body, adducted against his chest wall, supported by his left arm. On examination, there's inferior and anterior displacement of the shoulder. Which one of the following is the most likely diagnosis? So shoulder displacement as well as adduction, and he's already got struck to his right collarbone. That sounds like a clavicle fracture. So with clavicle fractures, usually due to violent upward and backward force, as might be sustained by landing on the outstretched hand or direct trauma. Less common by blows or falls on the point of the shoulder or by direct violence. Usually they're somewhere along the middle 1/3, at the middle 1/3 after 1/3 junction, because that's where it's the weakest. And accurate reduction is usually unnecessary, but you just put them in a sling for about 10 days to relieve the pain at the site of the injury. They usually heal very quickly anyways, 6 weeks in an adult, but then return of function comes back within 3 weeks in within 3 weeks, and 3 weeks of it fully healing in a child. Operative reduction, however, may be indicated if it's severely displaced or in the outer 1/3. And untreated, they can cause deformity and they can cause shoulder weakness as well. And that's how it would look like on the x-ray. Okay, next you had a 45-year-old accountant who came to A&E with pain and swelling behind his left ankle after playing a game of tennis over the weekend. So it's in his left ankle. He's sure he heard a snap when he lunged for a volley at the net, and he had to stop playing, and ever since he's been walking with a limp. On examination, he's unable to tiptoe on his left foot, and squeezing of the left calf demonstrates no passive plantar flexion of the foot. Which one of the following investigations would be most appropriate for this patient? So we're thinking he probably, ruptured his Achilles tendon or something of that sort. So it's 3 o'clock. So in order to clarify that, you'd want to do an ultrasound. Okay. With people that have, ruptured Achilles tendon or Achilles tendon rupture, the pain usually, it's like a dull, aching pain, but it's usually sharp at the very start, and they hear a snap, and then sometimes they can't. You find that they can't stand on their tiptoes. When you examine them, they have localized swelling. It can be palpable defect. You can actually palpate it. Sometimes they can't flex by themselves. They can't flex their feet. Yes, MRI would be definitive, but it wouldn't be the first thing that you want to do. You just want to do an ultrasound or an MRI, but MRI, you're exposing to radiation, so you might as well just get an ultrasound. It's faster, it's quicker, it will also make the same diagnosis. So you could do an ultrasound, and if it's not clear because there's blood or fluid, you would do an MRI afterwards. But you could always do an ultrasound because it's just as effective as an MRI. And then with regards to management, it would be not weight-bearing and either conservative or splint or surgical repair. Okay. Sorry, the next one, you have a 40-year-old male who's a driver of a car in a road traffic accident and he's complaining of abdominal pain. On examination, he's tachycardic and hypertensive. His abdomen is bruised and is tender all over with guarding on palpation. Which one of the following is the most appropriate immediate investigation? So he's just come to A&E, he has abdominal pain, he had an RTA. You want quick answers, you want to see, because the abdomen is bruised, so you're bruised and tender all over. So you're expecting, blood in the abdomen or something that might have ruptured. So to diagnose that, you could do a fast assessment. So a focused assessment with sonographer for trauma would be your first line. It's just ultrasound, it's really quick, and then afterwards he can have a CT if he needs to. So it's quick, it uses 4 views, the chest and the abdomen, and you use it. It's not sensitive for identifying all bleeding, but you will recognize if there is bleeding in hypertensive patients who need an emergent laparotomy, and also to check if there's any cardiac injuries or any penetrating traumas. You could do CT as well, but it takes a lot longer. So if you just want quick answers, a fast would be your number one. So next you have an 8-year-old child who's involved in an RTA who complains of being unable to move or feel his legs, but his plain films and neck CT show no evidence of fracture or dislocation. Which one of the following is the most likely diagnosis? So because the CT and the neck, all the films have shown nothing, it would be spinal cord injury without radiological abnormality. All the others, like Brown-Séquard ward or 곶 or 곶ᴇʟᴜ, it would have been shown on the films, and anxiety related for an 8-year-old who just had an RTA feels inappropriate. So spinal, they wouldn't come with, the inability to move their legs or feel them. So spinal cord injury without radiological abnormality refer to spinal cord injury without radiographic or CT evidence of fracture or dislocation. If you do an MRI, however, with the advent of an MRI, the term is ambiguous because you can find stuff in an MRI like an intervertebral disc rupture or a spinal hematoma or a cord contusion or ���atomyellia that you can see as well. And now it's more correctly named as spinal cord injury without neuroimaging abnormality, and recognizes that its prognosis is better than patients with radiological evidence of traumatic injury. It occurs in pediatric cervical spine injuries, and it's treated the same way as you treat spinal fractures, with immobilization and then physiotherapy afterwards. Okay, next you had a 50-year-old male with a history of gout who came to his GP with a red, hot, swollen first MTP joint of his left big toe. Which one of the following medications would be the most appropriate to prescribe? So gout attack, the first gout, when they're having a gout attack, you could give them naproxen, and then if that doesn't work, you could consider adding colchicine. And then once the gout attack is over, possibly starting allopurinol if they've had recurrent gout attacks. So yes, gout, disorder of purine metabolism. You have acute recurrent attacks of synovitis due to the crystal deposition. Not all patients will have hyperuricemia, so that's something to keep in mind. It's usually more common in men when they're around 46 years old, and then in women when they're older, like 60 to 80 years old. Usually it's characterized by excruciating, sudden burning pain. You get swelling, redness, stiffness, warmth of the joint, and it can last up to 2 weeks. And it could be spontaneous or it could be triggered. The triggers are things like trauma, alcohol, or exercise. And usually it's in the metatarsopharyngeal joint of the big toe, but it can affect other joints as well. And if they have long-standing gout, they can have the deposits of the crystals, the uric acid crystals. So first, you start with naproxen for all patients, unless they've had, gastric ulcers in the past and bleeding because of gastric ulcers, then you wouldn't want to give naproxen because naproxen is like a non-steroidal. So in that case, if non-steroidals are contraindicated, then colchicine would be your number one. But if they're not contraindicated, if they've not had any problems with non-steroidals in the past, they don't have asthma, none of that, then you can start with naproxen. And if that doesn't work, if that doesn't help, you can give them colchicine as well in the acute attack. But yeah, so that brings us to actual acute management. So you'd give them self-care measures would be things like ice pack, resting the joint, and then pharmacological options, we'd give them non-steroidal, so that's naproxen, and then if that doesn't work, colchicine, especially if non-steroidals are poorly tolerated, or if people are on anticoagulants, because then they're at risk of developing a bleed whilst they're on the non-steroidals. So anyone who has a contraindication to non-steroidals, you'd want to just start with colchicine, and then if that doesn't work, you can give them steroids if they're both contraindicated, and that would be for the acute management. In the long run, you'd want them to modify their lifestyle, diet-wise and alcohol-wise, to drink, responsibly, avoid certain things like beer, stout, port wines, and avoid dehydration, avoid eating, purine-based foods like red meat, and having other drugs that cause doing a medication review. So if they're on certain drugs that increase uric acid production, maybe switching them, and then also starting allopurinol if they've had 2 or more attacks in 1 year, or if they have renal insufficiency or uric acid stones, anything because of gout, any complications that they develop because of gout, you'd want to start them on allopurinol. But you don't start them in acute attack. You usually start it 1 to 2 weeks after the attack's resolved. And once you start them on allopurinol, if they have an acute attack afterwards, you don't stop the allopurinol, you keep it going, and then you treat the acute attack simultaneously. Okay, co-prescribed colchicine or low dose of non-steroidal to prevent a flare-up whilst initiating therapy, that's fine. Okay, Next, you have a 20-year-old Afro-Caribbean female who complains of a painful swollen joint in her hand and feet. On examination, she has a facial rash as well and multiple mouth ulcers. She's positive for anti-nuclear antibody. What's the most likely diagnosis? It's screaming, SLE. She has a rash, she has a joint pain, she's positive for ANA, and they get mouth ulcers as well. So it's common as well in Afro-Caribbean women, usually between the ages of 12 to 25. They can have a past history of spontaneous abortion or thrombosis because of antiphospholipid syndrome. But systemically, they can get fever, malaise, fatigue, weight loss. And then you have the specific features like the rash, the butterfly rash, or depending on which systems are involved, lymphadenopathy, hepatomegaly, myalgia, myositis, and things like that. But yes, there is the criteria for it. So criteria for SLE, 11 things that they might have. If they have 4 or more, then it's a diagnosis. So things like malar rash, discoid lupus, photosensitivity, oral or nasopharyngeal ulcers, non-erosive arthritis, pleuritis or pericarditis, renal involvement, if they have seizures or psychosis, hemolytic anemia or leukopenia or lymphopenia or thrombocytopenia, if they have the anti-DNA or antibody or anti-smooth muscle or anti-phospholipid antibodies, or if they have the positive anti-nuclear antibody. So in this case, she's had 4, the ulcers, the rash, the joints, and the ANA. Those are 4. 4 is enough for a diagnosis. And then the investigations you'd want to do, you do the routine blood tests. You might find anemia, you might find ESAs raised, you might find CRPs normal, and then the antibodies. So autoantibodies that you want to check for ANA, that might be positive in 95% of the time, anti-double-stranded DNA, the anti-smooth muscle one, the Rho, the anti-Rho, and the anti-LA, they're present in around 15%. And you can check for antiphospholipid antibodies as well, and the complement levels. Treatment, if it's mild, just resting, non-steroidals, or removing the cause that precipitated it. And then if they have severe disease, steroids or immunosuppressive agents, if that's ineffective. And because they're at risk of premature atherosclerosis, and they have an increased risk of cardiovascular conditions, we have to keep an eye on them for that, monitoring for all cardiovascular risk factors and making sure they don't develop any of that. Okay, the next one, you had a 55-year-old man with a long history of lower back pain who came in with difficulty stopping a stream of urine and is now frankly incontinent of urine and stool. He also complains of pain radiating to his legs. An examination of his perineum reveals saddle anesthesia and diminished lower limb reflexes. So in this case, you're scared, you're worried about spinal cord compression or cauda equina syndrome, especially because he has the incontinence, he has the saddle anesthesia, and he has the pain. These 3 all point towards, spinal cord compression or cauda equina, and you'd want an urgent MRI to find out why all this is happening. So cauda equina is low back pain, unilateral, bilateral sciatica. Especially if it's bilateral, your suspicion is raised even more. Saddle sensory disturbance, says bladder and bowel dysfunction, and variable lower extremity motor and sensory loss, usually because of mechanical compression of the cauda equina. So the cauda equina nerve roots caudal to the level of the spinal cord termination. They're the final ones. And though the lesion is technically to the nerve roots and represents a peripheral nerve injury, damage may be irreversible, and cauda equina may be a surgical emergency. So that's why they need an urgent MRI and urgent surgical intervention, plus or minus, depending on the cause. Okay. Next, you have a 25-year-old male who's involved in an RTA where he lost control of his car and overturned it into a hedge. The paramedics have stabilized his C-spine with a hard collar. He's maintaining his airway. Air entry into his chest is equal on both sides, and he's hemodynamically stable. Miraculously, he seems to have sustained no obvious injuries. However, he is complaining of pain in his neck. Which one of the following is the most appropriate? So the most appropriate, you want to see if he's got a fracture on his cervical spine. So you do a cervical spine x-ray. And then afterwards, if not, you can remove the C-spine and treat it as just, depending on what it is, soft tissue injury or muscular injury, if the x-ray rule out everything else. So radiographs of the C-spine, chest, pelvis, and fast are adjuncts to ATLS. So imaging is considered helpful, but should be used, carefully and not interrupt or delay the resuscitation process. He was hemodynamically stable, so it would have been fine. And when appropriate, you can, postpone the imaging until after the second survey when you've done the investigations and everything else and the management. Cervical spine radiographs are not indicated in patients who are awake, alert, sober, neurologically normal, have no neck pain or midline tenderness, or can voluntarily move their neck from side to side and flex and extend it without pain. Then they wouldn't need a cervical spine. But he had pain in his neck, so he could have had it done. In all other patients, you can get a lateral AP and an open mouth odontoid view. On the lateral view of the cervical spine, you can see the skull, the base of the skull as well, and you can see the first thoracic vertebra. But yeah, that's okay. And the next question you had, a 22-year-old male who was stabbed in the neck. Below his neck, he complains of ipsilateral loss of proprioception and motor function, with contralateral loss of pain and temperature sensation. Which one of the following is the most likely diagnosis? So this half and half. The fact that he has ipsilateral loss of proprioception and motor function, and then contralateral loss of pain and temperature sensation, that goes with Brown-Séquard syndrome. Just having a look at the other options, it doesn't fit with any of the others. Brown-Séquard, you have incomplete, transection of the spinal cord, or a lesion that's, incompletely affecting the spinal cord, and you get like a picture where there's only half the part of the spinal cord is affected. You get ipsilateral loss of proprioception and motor function, and then on the other side, you get loss of pain and temperature sensation. You rarely get it, but it can happen when you have penetrating trauma to the cervical or thoracic spine. And usually you can get it with herniated discs as well, cervical discs. Okay, and then finally you have a 33-year-old male who has cut his left wrist deliberately with a Stanley knife. He's now unable to abduct or adduct his fingers, and he's lost sensation to the fifth digit and the medial half of the fourth digit and the medial part of the palm. Which of the following anatomical structures is most likely to be injured? So it's either median or ulnar, but because of the distribution and the fact that he can't adduct or abduct, it's more ulnar than it is median. So it's the ulnar nerve that he's injured in this case, and that's why he's unable to adduct and abduct. And the ulnar nerve also provides a sensory sensation to the fifth and medial half of the fourth. And you have a sign called Fromment sign when the patient's asked to adduct the thumb, like holding a pencil, and the patient will instead hyperflex to compensate because he can't actually do the adduction.